ladies and gentlemen, and thanks from the chairwoman. Thanks of Omics Group, because it has created a great opportunity for me to share my experience with you. I would like to talk about our article, Abdominal Obesity Phenotype.
Speak just a little slower, please.
Abdominal obesity phenotype and risk of cardiovascular disease in a decade of follow-up, which was published in Atherosclerosis. In February 2015. All of us know we face an upward trend in abdominal obesity and metabolic syndrome, which has consequently led to the cardiovascular disease. Obesity is a heterogeneous phenotype, and risk of health-related outcomes in different obesity phenotypes is a controversial subject. A combination of obesity and metabolic components leads to involvement of different obesity phenotypes that may have different risks for future health outcomes, such as CVD. In this regard, metabolically healthy obesity, MHO, is in the center of attention, the benign nature of this obesity phenotype. While many studies suggest that MHO is a relatively benign condition, in comparison to metabolically unhealthy phenotypes, others show that in longer follow-up, the so-called benign obesity might become dangerous when compared to the metabolically healthy non-obese. Although uniform definition for MHO exists, most studies in this field use BMI, and recently some have also used abdominal obesity measure like waist circumference. The reason for this matter is that abdominal obesity measures may better predict CVD in comparison with BMI. Therefore, it is clear that using visceral fat measurement is a reasonable approach that provides deeper insight into the nature of different obesity phenotypes that include MHO and MUNAO. With the positive data about abdominal obesity phenotype, we use waist circumference and metabolic syndrome components, as well as insulin resistance, to class abdominal obesity phenotypes. We then compared the incidence of CVD in the healthy and unhealthy abdominal obese participants over 10 years follow-up. Tehran lipid and glucose study is an ongoing prospective cohort study being conducted to determine the risk factors of non-communicable disease among a group of Tehranian urban population. In Tehran and lipid glucose study, 50,000 participants more than 3 years old were selected by a multi-stage cluster random sampling method and were followed for 4 phases, at least 1 decade. In our study, 54 participants were candidates, but only 64-30 were entered in the study after being filtered by exclusion criteria, and you can see the exclusion criteria. And 692 participants were omitted because they're missing data of follow-up. Therefore, our attrition rate was 9.7%. Abdominal obesity was defined as a national waist circumference cutoff for both gender, and metabolic component was classified based on JIS criteria for having at least 1 metabolic component. Of course, waist circumference was not used because abdominal obesity was implemented for categorization of obesity phenotype. JIS criteria, one of the criteria for metabolic syndrome. We have many criteria for metabolic syndrome. For example, WHO enhance and like this. But JIS is an abbreviation of joint intermean statement, because opposite of IDF, we use, and NIH, we use national waist circumference cutoff for each country.
Can you explain this criteria? I think that what your slide. What are the criteria?
Yes.
What are the criteria?
Yes, yes.
Slide.
Yes. This criteria is FBS more than 100 milligram per deciliter, or fasting triglyceride more than 150, or fasting HDL above than 50 for male and 40 for female, and blood pressure more than 130 millimeter HD, or diastolic blood pressure more than 85 milligram. If more than one criteria the participants have, we categorize that metabolic unhealthy. And if one or less negative, or one, we put it in metabolic healthy. Is it clear? Yes, waist circumference was not used, because waist circumference was not used, because we categorize abdominal obesity and non-abdominal obesity based on waist circumference. Waist circumference was not used in metabolic syndrome criteria.
But what you say, the same thing. So if metabolic components were included, so in addition to the waist circumference, right?
Yes. Yes.
Or metabolic unhealthy with the waist circumference.
Yes. As I mentioned before, participants were classified based on metabolic syndrome and abdominal obesity in 4 phenotypes. Metabolic healthy non-abdominal obese, MHNAO as a reference group. Metabolic healthy abdominal obese, MHAO. Metabolically unhealthy non-abdominal obese, MUNAO, and metabolically unhealthy abdominal obese, MUAO, the worst group. And also we evaluated insulin. Insulin resistance with HOMA-IR index in only 3844 participants, because we have their insulin data. And we divided abdominal obesity phenotypes based on insulin resistance, insulin sensitive non-abdominal obese, ISNAO, insulin sensitive abdominal obese, ISAO, insulin resistance non-abdominal obese, IRNAO, and insulin resistance abdominal obese, IRAO. You can see fatal and non-fatal coronary heart disease and stroke as our CVD outcome definitions. The regression model was used and hazard ratio was calculated. Cox proportional hazard ratio used in our analysis, and hazard ratio was presented as unadjusted and multivariable adjusted for relevant confounders. Psychosocial, socioeconomic, smoking, educational level, family history of premature CAD, and like so. Baseline information shows that 42.7% were male, and the mean age 47.4 years. And 36.8% were metabolically healthy, and 52.7% were abdominal obese. The prevalence of MHAO phenotypes was 12.4% of the total population and 23.5% of the abdominal obese population. MHAO phenotypes were older and less educated and had more unfavorable metabolic components. Okay, okay. Yes, yes. Yes. Okay. The mean age was middle age, 47.4. And the percentage of the male was 42.7. And you can see these different phenotypes. In this table shows different phenotypes and baseline characteristics. This is the metabolic characteristics. You can see. MHO, this is the reference group and this is our target group. MHAO were older and less educated significantly compared to the reference group. And they had more unfavorable metabolic components compared to reference group.
So these were the ones, going back, so these were the ones that that had higher circumference. Because I thought the MUAO was like the worst kind.
Metabolic healthy abdominal obese. They have 0 or 1 metabolic component, but abdominal obese, based on national waist circumference cutoff. For example, you imagine 90 centimeters is the national cutoff for both gender, and they above the 90 centimeters waist, have waist circumference, but they have 0 or 1 metabolic component. We classified these groups as metabolic healthy, but abdominal obese.
So they were less educated and were older.
Yes. This is significant, statistical significance. As you can see in the Kaplan-Meier, we have 638 CVD events. 102nd of them were fatal during 10 years follow-up. And the overall survival rate means freedom of CVD events in this Kaplan-Meier shows 96.5% in reference group, 92.2% in MHAO, 90.7% in MUNAO, and as can be expected, the worst outcome in MUAO, metabolically unhealthy abdominal obese, 85.5%. The main important tables shows that the hazard ratio for CVD events in different abdominal obesity phenotypes. All of groups, including MHAO, had a higher risk for CVD compared to the reference group. This is the hazard ratio for, and the worst group, you can see, 4-fold. After multivariable adjusted, as can be expected, the crude value of hazard ratio should be lower, but surprisingly, still is statistically significant. This further emphasizes that abdominal obesity would be considered as an independent risk factor even when metabolic covariates are included and considered in the model. Metabolic healthy, abdominal obese, metabolically unhealthy, non-abdominal obese. As you can see, the same pattern was observed in abdominal obesity based on insulin resistance. Insulin sensitive abdominal obese had a twofold risk for CVD events compared to the reference group. This risk is more prominent in insulin resistance non-abdominal obese and insulin resistance abdominal obese. Therefore, obesity, even in absence of insulin resistance, is associated with increased risk of CVD. Insulin sensitive abdominal obese, insulin resistance non-abdominal obese. This interesting figure shows that regardless of healthy status, those who have abdominal obese are at increased risk compared to the non-abdominal obese. We divided two groups, metabolically healthy and metabolically unhealthy, and you can see abdominal obese had the higher risk for the CVD events. And also, another figure shows that regardless of presence of abdominal obesity, metabolically unhealthy participants are at great risk of CVD events. Two-part, non-abdominal obese, abdominal obese, and you can see metabolically unhealthy had a higher risk for CVD. What we need to do is establish a uniform definition for obesity and metabolic health condition. We should also determine a longer follow-up and other more type of outcomes such as all-cause mortality. These findings highlight that the importance of both abdominal obesity and metabolic unhealthy condition in predicting future health outcome. We believe that MHAO is not a benign condition when compared to the healthy individual participants. Therefore, in order to prevent any future CVD events, suggests that abdominal obesity should be prevented or stopped, even in absence of metabolic components. In this place, I have to thank of Professor Azizi, the chairman of Tehran Lipid and Glucose Study, the unique cohort study in our region, and Professor Hossein Panah, the leader of this study. And this is the city where we conducted our study, Tehran, a beautiful mega city in the Middle East. Thanks for your attention and your time.